minutes each, and this will be followed by vote of thanks by General Secretary. Now, please, I invite Brigadier General M Mahbubul Alam to start his presentation. Mahbubul Alam, please.
Thank you, Nasim Bhai. Thank you, everyone. Happy New Year. Happy New Year, everyone. আমাকে শুধু শোনা যাচ্ছে নিঃসন্দেহে?
হ্যাঁ, শুনতে পাচ্ছি আমরা।
Already there is 50 participants joined. Once every other day, Professor Mokaram is present. I took my slide to him just to get the solution, and that was my period of learning. Great period of learning. Professor Muhammad Kamal, my teacher, he is also present. There is our webinar is great and resourceful. I am thankful to Professor Ashim Ranjan Borua, President BAP. He is sick. We are praying for him. And the Secretary Nul Kobin, grateful to providing this platform to talk. I am exciting and thankful to Dr. Humayun Kamal. We'll get insight and expert opinion from him. We learn from him lymphoma, and we are still learning from him. Dr. Ferdowsi, the long experience with lymphoma, he's working in a premier institute of the country. Lieutenant Colonel Wasim, he is a good command on lymphoma. He's now working at Kuwait. Thank you, everyone. Exactly, I do not know what is your expectation from my presentation. May I share my slide?
Sure. Please share.
This is actually, it's nothing solid and crystallized draft at the end of presentation. It is simply a sharing of a practicing pathologist everyday's pleasure and sorrow. By sharing my experience, actually I am trying to learn myself, and I hope the postgraduate student and junior pathologist will get some way, get some thing to progress forward, and actually they are my target audience. This part, diffuse and large, comes from histomorphology, and immunohistochemistry defines the B-cell phenotype, identify the B-cell phenotype. So this is a morphological aspect. From morphology, we get the follicular pattern, but nodal pattern versus the diffuse pattern, the small cells versus the large cell. Today's most of the senior pathologists of Bangladesh grew in 80 and 90s in the heavy dominance of working formulation. Before that and after that, much water has been flown through the rivers to the Bay of Bengal, but still we are stuck in 1982. In 2016 classification, WHO includes clinical feature, morphology, immunophenotype, and molecular genetics to define the individual entity of lymphoma. And this part of the long classifications of lymphoma is my area of talk today. And this is a larger view, the growing list. My today's focus on this area in relation to my cases and the immunohistochemistry. This is a recent report from Dhaka City. You can see that there is a intermediate. Actually, there is nothing is existing in the intermediate grade, but the practice of immunohistochemistry in Dhaka City is very limited. and experience is also limited. My today's presentation mainly to discuss the immunophenotypic or immunocharacteristics of diffuse large B-cell lymphoma. My presentation is divided into 3 parts. The first part I will my approach to the diagnosis of diffuse B-cell lymphoma. In the next, I will discuss the immunophenotypic characteristics to identify the molecular makeup of DLBCL. And the last part, this is more interesting, few selected cases of this series. So rule out the non-hematoma lymphoid malignancy is the starting point. And for the beginner pathologist, for the learner, this is important. But in today's space, it is difficult to discuss this area that much. You can see in the background, there is a prosthetic core, and if you take this slice to any senior pathologist of the city, I think their diagnosis will be prosthetic carcinoma. In the last 2 webinars, we discussed on the prostate pathology, and we do the immunohistochemistry, and it is proof that it is a B-cell phenotype. It involves the bone marrow, the trypan biopsy, and the aspiration morphology. So the wide range of non-hematoma lymphoid malignancy will come under differential diagnosis that may be undifferentiated carcinoma, neuroendocrine tumor, basaloid neoplasm, malignant round cell tumor, anaplastic tumor, melanoma, germ cell tumor, sarcoma, etc. In the appropriate clinical context, on the basis of morphology, you will select the lineage identification marker that may be CD45, pancytocretin, S100, synaptophysin, or vimentin. We have a little scope to discuss all these issues. So today, mainly we'll discuss how we will exclude the other lymphoid lesions and confirm the immunophenotype of diffuse large B-cell lymphoma. So you may screen the case with CD20 but CD33, but when the morphology is very much suggestive, in our lab, we do upfront immunohistochemistry panel for the DLBCL that includes CD20, CD3, CD5, CD10, BCL6, MAM1, BCL2, CMYC, CD30, Ki67. But sometimes we need other hematoma lymphoid markers to exclude the other mimicker of the diffuse large B-cell lymphoma, like blastic variants of tumor, or sometimes the Hodgkin lymphoma, even reactive conditions by CD45, CD43, CD15, CD30, cyclin D1, CD138, kappa lambda, LK, ADT, EBV virus, CD21, CD23. These are the markers we may need to exclude the other lymphoid lesions. So a little break for a minute. Any postgraduate student can answer these questions. You can unmute and answer this question on 30-second time. What are the CD20 negative B-cell tumor? So in the next slide, this is the algorithm, immunohistochemistry algorithm. There are many algorithms try to identify the subtype of lymphoma. Usually the CD5 positive tumor, we don't think that would be a diffuse large B-cell lymphoma. If it is a CD5 positive large B-cell lymphoma, we have to exclude with other markers, the other CD5 positive tumors. Here, a few cases, the 4 or 5 cases in the morphology. The most common morphology, immunohistochemical approach, starts with the morphology. So here in the right corner, this is a centroblastic variant, the vesicular nucleus, multiple chromatin dot in the nuclear membrane, medium to large cells, discursive cells. Another common variant is the immunoblastic variant, immunoblastic type, where the prominent nucleoli in the central nucleoli, large cells, eccentric to some extent. And another third common variant is the anaplastic variant. Morphologically, there are spectrum of anaplasia. There may be a wide spectrum of morphology. Sometimes lymphoma, DLBC may confused with other tumor like non-hematolymphoid malignancy like carcinoma. Sometimes one common problem we face in the morphological point of view, the tumor cells may not be a large, or exactly we do not can interpret it by the size or the nuclear features, but at the end we report as a large B-cell lymphoma. So on this basis, we can see few more slides. This is, you can see there are 4 cases. There are 4 cases. The morphologically, what is your impression in these cases? Probably this is the centroblastic type of variant, or there are round to oval nucleus, nucleoli prominent. They are little monomorphic, but nucleus is vesical. I think most of the people will call it a diffuse large B-cell for their first impression. We have also the same impressions. The first case, you can see this is a cervical lymph node, 56 years male, and the cyclin positive, of course CD20 positive. So you know the diagnosis. This is the tumor from the paravertebral tissue. Paravertebral tissue, the core biopsy, and the patient all B-cell marker and T-cell marker is negative. MPU is also negative. And we later know the history. The patient is a known case of AML. So this is a myeloid sarcoma, our conclusion. This tumor, you can see, these cells are CD7 positive. So this is a peripheral T-cell lymphoma, or the final diagnosis. This is a recent case in our hospital. This is also reported by Dr. Ferdowsi in the same report. Immunohistochemistry was repeated here, and the same, we have given the same report, T-cell lymphoblastic lymphoma. So these are the mimickers of diffuse large B-cell lymphoma. So morphology, from the morphological point of view, there is every chance of wrong report. So 2020, there are a number of cases submitted for immunohistochemistry lymphoma panel, and 178 was total number of specimens submitted, and among them 144 turns into malignant lymphoma, other 24 turns is as a non-neoplastic condition. So among these, 64 is diffuse large B-cell lymphoma. This is actually our today's story on these 64 cases. You know, the DLBCL is a heterogeneous, both clinically, phenotypically, and genotypically, and associated with the different clinical and prognostic features. And it diffuse large by accounting about 30% most common common lymphoma or common non-Hodgkin lymphoma. Apparently, the large cells appears to be sometimes is monomorphic, but we are concerned about the inequality of the large cells. We know on the basis of molecular features, the diffuse large B-cell lymphoma can be classified into germinal center-like, non-germinal center, and activated B-cell or activated B-cell phenotype, or unclassified. You know, the diffuse large B-cell lymphoma arises from the dynamic microenvironment of germinal center, and it is a malignancy is a multi-step process that is the accumulations of genetic and epigenetic accumulation of multiple genetic and epigenetic alterations. And gene expression profile, the finding of gene expression profile can be translated with immunohistochemistry. And there are a number of immunohistochemistry algorithms to identify the subtype of Hodgkin lymphoma. But most widely used system is Hens algorithm. And in this algorithm, there are 3 markers: CD10, BCL6, and MAM1. If it is a BCL6 positive, it is a germinal center B type. And if it is a MAM1 positive, it is a non-germinal center. BCL6 is also included. You can see the CD10 negative, BCL6 negative is a non-germinal center type, and BCL6 positive and MAM1 negative is a germinal center type. On the basis of immunohistochemistry, and it is about 70% cases, 70 to 80% cases, the immunohistochemistry agree with the gene expression profile. And on the basis of immunohistochemistry, our 64 cases, the most of the cases are non-germinal center type. It is about 74.6%, and you know, the therapeutic response differs with the cell type of origin, and it is with the standard frontline therapy, the prognosis or less response in activated B cell type. This is this is 2 cases. One is tonsillar tissue, and tumor cells are CD10 positive. So this is germinal center type. And on cervical lymph node of 48 years, these are BCL6 positive and MAM1 positive, is a nuclear stain, and they are activated B cell type. So within the in parallel to the cell of origin, diffuse large B cell lymphoma has a huge molecular heterogeneity, and there are cases single hit molecular rearrangement or double hit or triple hit molecular rearrangement by FISH. We can detect the CMYC, and concurrent CMYC with concurrent BCL2 and BCL6 rearrangement we call in the WHO classifications high grade double hit or triple hit lymphoma. But there are tumors where the single as a protein expression, CMYC protein,
Please unmute yourself, Dr. Mahbub.
Sorry, it will take a little bit of time. Can you see my screen? No. Can you see?
Yes, I
can see. You can see.
All right. So you can
Also, you.
there are MYC protein expression and concurrent expressions of BCL2 and BCL6. So these are considered as a double expression. You know, the double hit or triple hit lymphoma with a aggressive lymphoma with a poor prognosis. Again, the tumor with the double expressions, they are also with a poor outcome. But in the WHO classifications, the double expression lymphoma are not considered as a separate entity. And you can see in the diagram there are overlapping the protein expression and the genetic rearrangement, but there are some cases there are genetic rearrangement, but there is no expression of the MOSC protein, or there is MOSC protein expressions, but there is no genetic rearrangement.
আচ্ছা, স্লাইড শেয়ারিংটা হচ্ছে না।
Right, হচ্ছে না?
না, আমি পাচ্ছি তো স্লাইড, আমি দেখতে পাচ্ছি।
দেখা যাচ্ছে।
দেখা যাচ্ছে, আচ্ছা ঠিক আছে,
আমি দেখতে পাচ্ছি।
So I can continue.
Yes, you continue.
So in 60 among the 64 cases, only 37 cases actually completed the study of double expression, and there are 11 cases double expression is found, that is 30%. Usually the commonly among the diffuse large B-cell lymphoma, there are double expression is 30%, and it is more common with the activated B-cell type, but the translocation is more common, or rearrangement is more common in the germinal center type. So this is the image of the CMYC and BCL2 expression. Anyone from the trainee, from the postgraduate student can try to answer which one is CMYC and which one is BCL2. If you can unmute and you can answer, try to answer, only 30-second time. So the cutoff value, this is CMYC and this is BCL2. CMYC is a nuclear stain and BCL2 is cytoplasmic, but actually it is also nuclear stain also, cytoplasmic and nuclear stain, but here you can see it is mostly the cytoplasmic. So cutoff value for the CMYC is 40%, for the BCL2 is the cutoff value is 50%, more than 50% to accept as a positive. So there are stratification one after one stratifications, you can see, but what is the end of these stratifications? In this diagram, you can see there is a 60 to 65%. There is a cure of the diffuse large B-cell lymphoma with frontline therapy, that is R-CHOP therapy. But in 35 to 40% cases, it is refractory treatment or relapse immediately after initial treatment. And among these 35 to 40% patient needs aggressive therapy, including adult stem cell transplantations, but unfortunately only 40-50% patient can eligible for the transplantations due to the considering the age and morbidity. And again, these 50%, only 50% can only chemosensitive and can proceed for the stem cell transplantation, and only among them only 40-50% can be cured with the with stem cell transplantation. So ultimately, the 30% of the population needs some sorts of new drug or chemotherapy, and that is the unmet medical need. And in the future, the better understanding of the biology of diffuse large B-cell lymphoma and the prospective molecular classifications of lymphoma will play the major role for this patient. So again, into the slides, during this process of immunostaining, phenotyping study of diffuse large B-cell lymphoma, we got one case of CD5 positive large B-cell lymphoma, 4 cases of CD30 positive diffuse large B-cell lymphoma, and there are 2 cases of both CD10 and MAM1 diffuse large B-cell lymphoma. So actually little time to discuss all these things. This is a poor morphology, histomorphology of that, but the tumor cells are BCL large CD5 positive in the background, and You can see in this slide, this is a high Ki67 level. So we considered it's a diffuse large B-cell lymphoma, and we do cyclin D1 and SOX11, both are negative. I don't know the fish was required or not, but this is considered as a diffuse large B-cell lymphoma, CD5 positive. In this case, actually, this is also a retroperitoneal lymph node, and the morphology is large B-cell morphology, and this tumor is CD10 positive and MAM1 positive. These are considered as a double positive lymphoma, and it is recommended that if the tumor is CD10 B-cell and MAM1 positive, that should be screened for the IRF4 rearrangement. That is also another entity in the separate entity in the large B-cell lymphoma. In this study, in this series, in this series, in this series, you have already discussed the diffuse large B-cell lymphoma, not otherwise, and majority of the I have discussed the morphological variant and the molecular subtypes, and also discussed about the high-grade B-cell lymphoma. And the special type of lymphoma, there are very minor component, but we receive also one case of T-cell histiocytes large B-cell lymphoma. There are 4 cases of CNS lymphoma, one case from the atrial mass from the heart. Actually, one case chronic associated with chronic inflammations. 2 cases of primary medicinal B-cell lymphoma, 2 cases of plasmablastic lymphoma. So it is difficult to discuss as time limit all these cases. I'll show one case on the medicinal mass. This is the core biopsy. We have a number of cases in the medicinal mass during this in 2020, but most of the cases are landed into the blastic lymphoma, T-cell mostly. And this is a core biopsy, and there are more nuclear debris, the necrotic, there are large to medium to large cells, and the high power. And the tumor cells are all CD20 positive. There are focal CD5 or CD3 positive tumor. They are PAX5. And tumor cell are more characteristics. The tumor cell are CD30 positive and CD23 positive. So it's our conclusion is the primary medicinal large B-cell lymphoma. So actually, these are the part. I think we will be more interested on the selected cases. That will be more enjoyable. So I can discuss one case by case. So this is case 1. Patient presented with cervical limb adenopathy. And the core biopsy was done. Today, in this series, actually in the 64 cases, 22% cases, 22% probably this was core biopsy or small biopsy. So it is not recommended in the different organizations, including the WHO, to do the core biopsy. If possible, to do the intact lymph node biopsy. But day by day, the limitless shrinkage of size of the biopsy. So there will there so there will be limitless shrinkage of the size of the specimen, and that is a difficult part of the tomorrow's pathologist to know the architecture of the how will they assess the architecture of the tumor. And sometimes that maybe not be the representative samples. We have that maybe happen, but it is the reality. We have to accept it, and we have to change our morphological impressions from the large specimen to the small specimen. And you can see from this point point of view, there are cells within the mature lymphocytes. Cells have abundant cytoplasm, clear vesicular nuclei, prominent nucleoli. There are some pleomorphic cells. It is another time where it's a different cut or different stains, so the color is changed. But you can see here the scattered, diffuse, discohesive cell with pleomorphismic as well as sheets of cells, abundant cytoplasm, the gradually increasing of the power, high power view. You can see there are cells, there are bilobated, multilobated cells are there, bizarre nucleus. So morphologically, to me, it appears to be a differential diagnosis. What is your differential diagnosis in this power, the high power? A lot of number of slides I have shown you. This is the high power. So what is your diagnosis on this basis? So my differential diagnosis actually in this case is the metastatic carcinoma. It may be melanoma because of the prominent nucleoli, and it is a non-Hodgkin lymphoma, diffuse large B-cell lymphoma. It's a Hodgkin lymphoma. There are bilobated cells or pleomorphic or giant cells. So it may be other thing, other anything. So actually, I given these images in the Facebook group, and I also introduced a poll, but unfortunately only 3 participants is there. So 2 has called it as diffuse B-cell lymphoma, and 1 is Hodgkin lymphoma.
What about anaplastic large cell lymphoma?
That can be in the differential diagnosis. That should be actually
because the cells are large, present in the cell.
Right. The nuclear characteristics are not that much of characteristic, but it can be. Of course, there are pleomorphic cells. The analysis it can be happen. So we do the immunohistochemistry, and we do the cytokeratin and S100. Actually, we S100, and that are negative. We do EMA, that is also negative. This is CD45 positive tumor cells are CD45 positive. Tumor cells are CD20 positive, strong. These are the CD30, CD3. So the large cells are negative. Scattered cells are CD3 positive. CD15 is negative. CD30 is positive. So that is considered as the anaplastic. There is one of the possibilities that is CD30 is positive, but tumor cells are B-cell positive. It is already we have seen on the other slide. So what are the differential diagnosis of CD30 positive that may come? Tumor cells are strong PAX5 positive. So it's a B-cell nature of the tumor. So to some extent, anaplastic lymphoma may be excluded, anaplastic large cell lymphoma, and the tumor cell are, we have done the LK is also negative. Tumor cells are MAM1 positive, MAM1 positive. So tumor cell, there is a high Ki67 level. So you can see these things. This is a tumor, a pleomorphic tumor, pleomorphic morphology. The tumor cells are CD45 positive, CD20 positive, CD30 positive, PAX5 positive. Or other markers, the possible markers are negative. So our conclusion in this point is the diffuse large B-cell lymphoma anaplastic variant. But it will be open at the end. Actually, I will discuss the case. Discuss the question. I may be wrong. We may be actually in our diagnosis. Dr. Khaled probably present. He is also my colleague. Most all the cases and the preparation of the papers, he has participated very intimately. Thank you, Dr. Khaled. So next case, we can go to the second case. Second case, it's a 49 years male, right neck tissue. And you can see the morphology, very anaplastic morphology. The low power view, we can see the high power, gradual increase of the power. This is a large high power view. There are pleomorphic cells in this pod. There are multilobated cells, the single cells. There are variation, marked variation of the nucleus, prominent nucleoli. You can see the multinucleated cells. There is a bilobate cells. There are variation in the nuclear size, atypical mitosis. And you can see this is the very classic RS type cells. This is a mononuclear redistributed cells. This is another. Actually, I have taken on picture is the high power view in the oil immersion, which is not usually take in the histopathology sections. We taken multiple area, multiple places, multiple side, not from single focus, and it is a collage. So you can see there are bilobate cell, multilobated cells, classical RS-like cells, the prominent nucleoli, eosinophilic nucleoli. So what are the differential diagnosis? Hodgkin lymphoma, because there is high density of high density of tumor cells. And then maybe it is a diagnosis of anaplastic large cell lymphoma. And so anaplastic large cell lymphoma that can be differential diagnosis, high grade sarcoma. Do you have any other diagnosis? Other? So what are the differential diagnosis? I am also given it in the poll in the Facebook group. So there is a 10 participant who is shown is a anaplastic large cell in favor of anaplastic large cell lymphoma, 3 in the high grade sarcoma, 1 is the other. So with this morphology, we can see the immunohistochemistry pattern. So tumor cells are cytokeratin negative and desmin negative. Probably we do the pimentin that is positive. That's no value. These tumor cells are CD45 positive, CD5 positive, and tumor cells are CD20 positive. The most large cells are CD20 positive. Actually, the high power view to see that these cells are CD20 positive or not. These are CD20 positive cells. So background is CD15 the positive. Sorry for the low quality of the slide. This is, I don't know exactly why. If you take the photograph, a few months after the appears in the slide, I want solution from some technical persons.
What?
Water drop probably. These are white crystallized drop. So then C30 is negative, and the high power view, actually you can see clearly these cells are CD30 negative. So it is excluded. This is not a Hodgkin lymphoma. Now still we can think so, but it's a PAX5 that is a very strong positive. So you can exclude the diagnosis of Hodgkin lymphoma. It's also CD45 positive. That is also that's Ki67 levels also are high. So you can recapitulate the things. That is a very classical RS-like morphology, which anyone and junior pathologist will diagnose is a case of Hodgkin lymphoma, and we are learned in that way. But these are marker negative for the Hodgkin lymphoma. Hodgkin lymphoma probably is no more a morphological diagnosis. So our final diagnosis in this case is diffuse large B-cell lymphoma, anaplastic variant. Practically, when we preparing the slide for the presentations, somehow we find that we have not done the EMA, and though it is our initial diagnosis of anaplastic variant, with this marker, I do not know the anaplastic variant EMA has been excluded or not. Sorry, anaplastic large cell lymphoma excluded by this marker. Probably it is excluded, but even then we do the EMA in this case, and we do the OCT2 also because it is still B-cell lymphoma. So these cells are EMA positive, strong EMA positive, and these cells are OCT2 positive strongly. So will I change this diagnosis? I don't know exactly. My diagnosis is still diffuse large B-cell lymphoma, anaplastic variant, and we have done the LK. LK is also negative in this case. So It is not that LK positive large B-cell lymphoma. It is not like that. So usually we do the diagnosis of nodular lymphocyte predominant vascular lymphoma by EMA positivity and OCT2, but I am not in favor of the diagnosis of nodular lymphocyte predominant vascular lymphoma from morphological point of view. I am in favor of diffuse large B-cell lymphoma. I think we will discuss this case at the end of my presentation. So third case. Third case, actually, it is a little bit straightforward, maybe. It's cervical lymph node, 22 years male. And you can see the lymph node architecture. Somewhere the lymph node architecture is also preserved, also, not to the partially distorted. You can see there is no field, the lymphocyte, plasma cell, other lymphocyte, but you can see in between them there are little larger cells. This is again on plasma cell, lymphocyte, eosinophil, but you can see these are the large cells. Relatively, there are prominent nucleoli, there are sheets of large cells, there are irregular nucleoli, bilobated nucleoli, prominent nucleoli. There are more large cells, sheets of large cells. There are irregular nuclei, bilobated nuclei, and I can do these things. You can see there are multilobated nuclei, bilobated nuclei, large cells, sheets of large cells. So you can see actually the morphological pattern in ELSA is not probably exactly depicted in the taken images, but this is almost a morphologically very characteristic of background. Background is Hodgkin lymphoma. So our diagnosis is Hodgkin lymphoma mixed cellularity. First diagnosis, diffuse large B-cell lymphoma, because it shows sheets of large cells. So their morphology, some cells are anaplastic, irregular, so anaplastic large cell lymphoma. Peripheral T-cell lymphoma is also our diagnosis. But tumor cells, there are usually in this case, usually we, to reduce the use of number microscope, we first exclude the Hodgkin lymphoma because of small marker. So we do the CD20, the characteristic features more in favor of actually this hypod, these tumor, these large cells are negative for CD20. We do the CD3. So morphologically, it is more matches with the Hodgkin lymphoma, but the cells are CD15 positive, and tumor cells are CD30 positive also. And you can see that there are PAX5. I can see these compared to these large cells, compared to the B cells PAX5. These are the dim positivity. So we do not proceed further to increase the confusion. So we are diagnosis with these findings is a little straightforward Hodgkin lymphoma mixed cellularity, but exactly this the sheets of cell, the nuclear features are not that much characteristic of Hodgkin lymphoma. But so we are. I'm in favor. I was in favor of to label diffuse large B-cell lymphoma morphological point of view. So with this, actually, I'm proceeding to case 4. Actually, this is the last case. I will not create a burden on you. So, see, this is a case. Actually, I don't know exactly this will match with this presentation or not. But patient presented with the anemia since last January, and there is history of repeated transfusions, low hemoglobin, WBC count, platelet, and ESR. There is a probably that reason there are abnormal iron profile, and we received a bone marrow trephine. Usually, our physician hematologist when do bone marrow transfusions, he used to take one sample for trephine biopsy, another sample for flow cytometry. So it's a low power view of the trephine biopsy. You can see the there are marked suppressions of the granulopoiesis, myelopoiesis, erythropoiesis, and there is no megakaryocyte. There are no megakaryocyte. The bone marrow is packed with atypical cells. And in this case, actually, what's happened before we issue report, biopsy report, We look at the bone marrow aspiration report and flow cytometry report because they plays the major role in the diagnosis from the bone marrow aspiration. So in this case, as we find that the aspiration is blood that maybe happen in this case because the way it was in the different biopsy picture, but flow cytometry also negative. That is, they could not give any opinion. No new plastic procedure is going on. Serum iron profile is abnormal. That is a different issue. So ultimately, the main again, it is our responsibility of comes on our full responsibility how to call it, because we're seeing something. There is abnormal cells in the bone marrow, and there are prominent nuclear chromatin is open. There are atypical cells. There is no hematopoietic cells in the marrow. You can see another view. You can see another view. You can, and on this basis, actually, we ask for immunohistochemistry on these slides. But before that, we give a report with the low confidence, suspicious for acute leukemia. But I don't know if it's leukemia or not. So in the peripheral blood, there is a liquid erythroblastic picture, but there is no atypical cells in the bloodstream. So we do the immunohistochemistry, wide range of immunohistochemistry, especially at the very beginning. We started with the blast marker CD34, CD117. We do MPO, TDT. Even we go for CD4, other marker for the B cells, another marker for the T cells. Even you can see the CD5 all are negative. All are negative, but at the end we do CD138 that is positive in this case. So there are tumor. I have questions for the training at the very beginning. Which tumor can be CD20 negative? So one tumor CD138 positive tumor can be CD20 negative. So you can do the lambda chain. There's a strong lambda expression, staining of the lambda, and there is a weak staining of the compass. So there is a lambda restriction in this case. So there is no clue to the physicians what was the diagnosis in this case. Actually, in this case, the ESR was normal. There is no history of protein electrophoresis, though patient is also the EMA positive. And the tumor cells are MAM1 positive and CD43 also positive. So in many cases, when the diagnosis CD45 is not enough to identify the hematolymphocytes tissue, hematolymphocytes lineage. So in that case, you have to add CD43 also. And in this case, then after that, after our diagnosis in this level actually is the plasma cell neoplasm, and after that they do the serum immunoglobulin. In the serum immunoglobulin, actually only the serum IgG is mild low level, and the protein there is no monoclonal gammopathy, no monoclonal gammopathy, and there is a mild displacement of the IgG, kappa and lambda immune displacement. So but you can do the free kappa and free lambda. There is a marked increase of the free lambda chain, and that is more than ratio is more than 100, more than actually 1000. So the diagnosis of multileuma, the bone marrow involvement is that more than 20% of the cell, and the free light chain ratio is more than 100. We can call it a multiple myeloma. So our diagnosis from point of view is a one source of plasma cell neoplasm, and it can be a light chain myeloma. So in this case, actually, the bone marrow aspirations, on the flow cytometry is failed, but from the histopathology, bone marrow defined, we have given the diagnosis, and subsequently it is proved by the other laboratory features. It is a myeloma, and it is this morphology. It can if it is a lymph node, we will call it a plasmablastic lymphoma. So we are at the end of my presentations. There are a few more cases, but I will not discuss today. So already I have taken much time. So we are passing a very difficult time past the very difficult time to and still passing very difficult time. Our life is disrupted with the pandemic COVID-19, and our one beloved pathologist and unique personality, Dr. Nazmul, is struggling in the hospital with high flow oxygen. Our brilliant pathologist and academic powerhouse, Dr. Tawfiq, we lost him. They are all our prayer. Today, with that, with all this, I am doing conclusions. Actually, it is the classifications of the diffuse large B-cell lymphoma is rapidly changing, and the precise diagnosis is essential to institute the correct therapy. And in the future, we have to incorporate immunohistochemistry molecular features in the precise diagnosis of diffuse large cell lymphoma. And as a pathologist of Bangladesh, we have to work along to be on the long way, to be on the road of international clinical practice of medicine. Thank you very much. Thank you, everyone. You can ask the questions, and you can the session may be open for the discussions. Thank you, Nastin Bhai. You can.
Thank you, Brigadier Mahbubul Alam, for your very nice and elaborate presentation. আমার মনে হচ্ছে খুব অনেক কষ্ট করে খুব সুন্দর করে আপনি এই প্রেজেন্টেশনটা করেছেন, এবং এটা it's a quite an learning experience to us. Not only the beginners or our students, but also us. We are also will be greatly for this presentation. Now, coming to the chat box, there is not much questions. Mostly these are greetings. I would like to now refer to the panel of experts. Before going to Humayun Kamal Islam, I want to invite Professor Firdausi Begum with dealing with lymphoma cases. She may share her experience regarding diffuse large B-cell lymphoma in her institution. Professor Firdausi Begum, please.
Thank you, Professor Muhammad Nasim Islam, for inviting me. Actually, I don't have exact data about my experience in my center, but the most common that I have signed out till today is the diffuse large B-cell lymphoma, and I'm only subclassify them as germinal center-like type and non-activated B-cell-like, and that is the most common type. And so far I remember, among the variant of diffuse large B-cell lymphoma, I have signed out few cases of T-cell rich B-cell lymphoma, some cases of plasmablastic type, mediastinal large diffuse B-cell lymphoma, ALK positive diffuse large B-cell lymphoma, gray zone lymphoma, and I have signed out a case of diffuse large B-cell lymphoma associated with chronic inflammation. That's my experience. And as you know, I'm not the lymphoma specialist. Actually, I'm general pathologist, and in my center, I have to do all type of diagnosis. And among them, lymphoma shares the most large part, because in my center, other than ERPR hard to new, next common is the lymphoma that I
How
got
many
in my center.
reagents do you have in lymphoma panel?
Excuse me?
How many
How many?
reagents
How?
or antibodies you use in your lymphoma panels?
Marker.
In case of
present?
marker, yes,
Yes,
I understand.
marker.
In case of BCL classification, I've got BCL6, CD20, CD19. I don't have CD19. I have CD15, 30, CD1, 38, PAX5, and the all marker that need to classify lymphoma of small size, that is cyclin D1, CD10, and CD23, and ALK1. And I have also got T-cell marker, CD2, CD3, CD5, 4, 8. These are the markers we have. Cup and lambda.
Thank you, Professor Firdousi. Now I want to invite Wasim Selimul Haq. Do you have any comment, please?
Sir, at first, sir, I would like to start by, sir, what should I say? My gratitude and reverence to my teachers, respected senior pathologists and my colleagues, as well as Brig Gen Mahbubul sir, Professor Firdousi Appa, and Humayun Kamal. He's the basically centerpiece of today's gathering. So basically, one thing from the presentation of Mahbubul sir, the last case, basically, what I want to say is that the nuclear feature of that, plasma cell neoplasm was absolutely very much typical of a blastoid neoplasm. Morphological diagnosis of suspicious for acute leukemia was all right. Only the interesting feature of this tumor was that the tumor cells were having abundant cytoplasm, eosinophilic, some granular cytoplasm. Ultimately, the whole feature would, for a junior pathologist, plasma cell neoplasm should also, strike their mind, especially when the cells are having this sort of cytoplasm, abundant cytoplasm. And one more thing, sir, just I want to add for the junior pathologist. It is the immunohistochemical evaluation. In our country, at first, the junior pathologist must keep in mind the fallacies of immunohistochemistry, the aberrant expression as well as loss of expression, because these are abundant in tumor. When we learn it, we think that all the lymphomas should be CD45 positive, but all B-cell tumors are CD22. But these are not the rule. Aberrant expressions are there, loss of expressions are also there. And secondly, poor tissue fixation in our country is a practicality, which leads to erroneous interpretation of immunohistochemistry. It's a very real problem. And especially, I can give one example. Suppose CD68 and S100. These commonly take, non-specific, tissue takes non-specific, what should I say, stain. And if the tissue is poorly fixed, this non-specific stain can be erroneously interpreted as positive. So ultimately, the aberrant expression or loss of expression coupled with this, poor tissue fixation may lead to wrong diagnosis. So to avoid this wrong diagnosis, three things we should keep in mind. First of all, we have to have sound knowledge on the immunophenotype of the tumors. Secondly, we should have sound morphological evaluation. For morphology, to me, is basically a sort of double-edged sword, because over-reliance, both over-reliance or under-reliance on morphology can lead to erroneous diagnosis. We must have to have a very good, sharp morphological diagnosis. And the third, but not the least, is the clinical finding of the patient. Basically, at times, it is the clinical finding that ultimately gives the diagnosis, not the slide on the article. Thank you very much, sir. And it's a very nice presentation.
Thank you. Now, Professor Humayun Kamal Islam. Please have some comment.
We want more elaborate and also highlight on the cases if there is something doubt in the diagnosis of the cases.
Sure, I'll try my best. First, salam and greetings to all of you, and thanks Professor Nasimul Islam and the BAP for inviting to this excellent webinar. Professor Mahbubul Alam, you did an excellent job in presenting the very heterogeneous and complicated entity of diffuse large B-cell lymphoma in 1 hour. It's a complex entity, but at the same time, it is the most common of the adult, one of the most common of the adult non-Hodgkin's lymphoma, comprises about 30% of the cases. And many of them are extranodal, almost 40%, depending on what literature you follow or read. So for a general surgical pathologist perspective, it doesn't matter what organ I'm finding out, you may encounter some of these diseases in every organ system. So having a first-hand grip on working up these cases is very critical and crucial. And as you rightly pointed out, morphology is our foundations and always should be the basis in making the differentials. Just like we say when a patient walks in a doctor's room, the differential starts from there. Similarly, we should start our differentials starting from the age and the clinical presentation if available, which always I mention is a difficult information to retrieve from our clinical colleagues, but we should give an effort, especially in the setting of lymphomas, because the diagnosis will strikingly change depending on what's the clinical presentations in a given individual. And then we concentrate on morphology. And some basic clues in the morphology is very helpful. You elegantly pointed out some of those features in your cases. I mean, first thing, is it benign? Is it malignant? We ask that questions. Then if we think it's malignant, how does the cells look like in the perspective of lymphoma workup? Is it small cell? Is it large cells? Is the pattern has any histologic pattern, has any clues? Is it a diffuse pattern? If it is a nodular pattern or patternless pattern? So that kind of give you the initial narrowing down of entities. In the backdrop of DLBCLs, of course, as the name says, it will have that diffuse pattern and it will have that large cells. So then you try to, narrow down further what entities in the diffuse and large cell lymphoma categories are included. And we try to see from a lineage perspective. First thing, is it a B cell or T cell? If it is a mature cell or immature cell, that helps us to further narrow down our differentials. If we exclude the lineage, the T cells are out because we know some morphologic differentials will be there. Through your cases, you said anaplastic large cell lymphoma, as well as the peripheral T cell lymphomas, and the different subtypes of DLBCL, as well as mimickers of DLBCL's other B cell lymphoma variants will be in the different. Well, it is a diffuse form, it is large cells. So can I call it DLBCLs, or there are something else to work up on those ones? And at that point, we have our challenge, how much immuno is available or ancillary tests are available at my disposal. I mean, if nobody has that luxury, and of course in our motherland, extremely difficult to have the luxury of ordering 10, 15, 20 immunostens. They're very expensive workup for these ones. Even in the developed countries, it's not, it seems like we have a lot of abundance of stains. We do have, but we get always a feedback, okay, what's the justification of using this much of markers for this kind of cases? So you have to rationalize using of every immunostent. So you try your basic to be cell markers, narrow down from there, and Professor Mahbub outlined, and for this he was mentioning, whether majority of the cases will be whether it's a germinal center or activated B cell origin, because that is a big outcome difference. One will have 30 to 35% 5-year survival, activated B cell, and sometimes they give additional drug with the R-CHOP for the clinicians to treat this patient. In contrast to the German center, which has a 60 to 70% 5-year survival. So that one they try to treat more conservatively with the R-CHOP only. So that's our first important task, to at least help to distinguish these is, I mean, 1-2% of our practice, not more than that. If we take care 90% of the cases, with that we achieve our first milestones and goal. And those rare cases, and the evolving one is a high-grade B-cell lymphoma. Just one comment I want to mention about that. Professor Mahbubul pointed out that chart from the WHO, the different types of large B-cell lymphoma. And the first category, diffuse large lymphoma. And at the bottom, you have that high-grade B-cell lymphoma. But when you want to label anything as a high-grade B-cell lymphoma, avoid the term DLBCL, because it's not a subtype of DLBCL. It's a separate entity from the DLBCLs. And those are very complicated, but morphologically try to see if it is more a little bit of plastic looking. And Ki-67 is very useful. It usually has 90% or above proliferation markers. So, and then if you do have BCL2, CMYX, BCL6, you can further narrow down whether it's a double hit, triple hit. Even over there, there is an NOS category, which does not show any of these mutations. So that's an evolving field. Every time something new comes up, I mean, a new dimension, a new horizon opens up. So we need to cover our basics, those 95% of the cases, and then do our best to address those 5% or less cases for the unusual ones. So that will be my tips to all emerging postgraduate students and at the beginning in the practice to address these lymphoma cases. And back to Professor Mahbub's comments about the cases. Yes, I agree with that. The case 1 and case 2 are having those anaplastic features. So just one entity to consider in the differentials for those. There is still WHO in the latest edition kept one of those intermediate categories they call diffuse large B-cell lymphoma or B-cell lymphoma with features intermediate between DLBCL and Hodgkin, especially for the second one. That could be another one. Otherwise, it will just be a diffuse large B-cell lymphoma anaplastic variant. The third one is, I agree, it's a classical Hodgkin lymphoma, and so is the bone marrow. It's probably, you don't have those CRAB symptoms, then you can just call it a, I don't know if it is a solitary lesion or not, then you can call it a plasmacytoma, or if it is a diffuse process in the bone marrow, depending on where it's coming in the bone marrow, then of course, plasma cell myeloma is the right diagnosis for cancer. So that's a few comments from my end, and we need to keep our hope. These are strong words. So whatever we have at our disposal, we try to maximize the use of that one and make the best outcome from those morphology to the limited immunostains to work up our cases, and always keep up the relentless efforts to move to the next step, because limit is the sky. If you remember Professor Zaman, I believe 1993, when he first did his those conferences, there was not that much immunos, not that much. We have come across a lot. So that's a very optimistic note, and most optimistic mean abundance of immunos coming in. So what could be done next step is a little bit of coordination. Not every center is possible to keep all the immunostats. Maybe there will be a general walk-up, and then there should be a referral of the cases for the next walk-up, or get the immunos done for the unusual or rare markers in a centralized few centers to work on the cases. So with that note, and also expressing my sympathy and condolences to all the brave hearts that we lost in our community, including Professor Islam. That was such a shocking news. I still couldn't believe. I was talking to him just the other day. We are in contact. So let's hope and pray that pandemic and everybody continue to stay safe and well. Thank you very much.
Kamal,
thank you, Professor Kamal.
Dr. Nasir, I have actually one question to Dr. Kamal.
It's open.
Actually, one problem we face during, there are a lot of limitations there in our immunohistochemistry we have presented, but we have not discussed, I have not discussed that thing. So one thing is that morphologically we are convinced that it's a diffuse large B-cell lymphoma, but we usually add, it is not required in the diagnostic criteria, the Ki-67. So we add Ki-67 and we find that the Ki-67 is very low. Is it a technical failure or the clone of the antibody, or what is the problem? Can you?
Yeah, I will address that in two aspects. First, it's not needed for making the diagnosis, you rightfully pointed out. You will use it judiciously like any other immunostains when you are dealing with a gray zone morphologically looks like it's probably a high lymphomas, has a little bit of blastoid morphology, very blue tumor, not that much of moderate cytoplasm. I mean, nucleus is not kind of clearing of the cytoplasm, which we typically see in the garden variety of DLBCLs. In those cases, you can use the Ki-67. Also, we use it for any suspected Burkitt cases. These are the two cases, two types. We always try to use the Ki-67. And when you interpret the second way of responding to your questions about technical feasibility, it's usually is a nuclear stain and works good. I mean, this is one of the stable antibodies as compared to many other antibodies. One common thing sometimes, there is a subjective variations. Say the case is presented, there are a lot of reactive other cells in the background. And if you compare it with the PAX5, you see how much is my PAX5 positive, the neoplastic B cells, and then do an eyeball matching out of those B cells, how much is coming positive. And that's how you try to get, not among the whole slides, because there are other cells in that. So I put in my report that Ki-67 is positive 80% of the neoplastic cells based on eyeball.
Thank you.
Thank you. It's open for all. Any question from or any comments?
Yes, I can. Can I make a comment?
Yes, sir.
Of course, sir, we haven't listened.
A few words.
Yes, sir.
Hello, everybody, especially Kamal from USA. Hope everybody is all right in this troublesome COVID days. For diagnosis of lymphomas, actually we have that immuno facilities only in a few centers. And in most of the centers, as Dr. Kamal was pointing out rightly, that not many antibodies are there. So they are also overburdened with the workload. So for the practicing pathologists in different medical colleges and private institutes and laboratories, what they should do is, for every lymph node, they should carefully assess histology. And then in our context, what they should do is, if they suspect this is a lymphoma or a Hodgkin, make a comment like suggestive or things like that. Because nowadays, people around and the newspaper and other people, they are not happy about the doctors. And if you straight away write lymphoma, and if it comes out that it is not a after immuno, they always do this. And then for lymph node biopsy, for needle biopsy, I also get quite a good number of lymph node needle biopsies, core biopsies, which I think not a good practice. You must add a comment below that core biopsy does not or is not a good practice for diagnosing lymphoma. Please perform a total lymph node biopsy with a soft tissue, perinodal soft tissue. If you think that this is needed, sometimes there is tuberculosis or other diseases that then you can give a diagnosis of that. Because lymphoma can, core biopsy can miss many areas. And the third point is after you suspect this as a lymphoma, you refer to a center for immunohistochemistry. That is a must. Without immunohistochemistry, you cannot, sometimes you cannot confirm a lymphoma from a reactive. And also immunophenotyping is very important for, as you already know. So what my conclusion is, for diagnosis in the country, you have to be careful. You have to be, HE section should be good, and then your comment should be very careful. And then refer it to a center where there is full immuno facility. And thirdly, we also should develop other centers with full-fledged immuno facilities, special full a good panel of lymphomas, different markers, and cooperation between the centers. So, like if I am lacking one antibody, I can take during sectioning, I can take additional sections and send them to that center, and vice versa. So this will, because our country is small and we are practicing in mostly in the Dhaka, is immuno, so it will make more our lives more easy and more and the diagnosis more accurate. Thank you very much. Salaam, sir. Salaam, sir.
Can I comment
Sir,
a little bit?
of course, sir. Makaram, sir, please.
I'm sorry. I was not there because I would like to congratulate the organizer. They have made this session, today's session, at least very time within the fixed time they have concluded it, because the previous session they took a long time, so I couldn't wait till the end. I like to congratulate Professor Mahbub for his excellent presentation, starting from the preliminary stage of original classification, rapport and others, to the latest conclusion. His slides are quite good. I should rather say it is quite acceptable one. The common thing, the most important thing I wanted to say has already been told by Professor Humayun and Professor Kamal. So I would not go into that thing. The most important in this country, in our country, I would rather say that we can theoretically, we can talk a lot about it. I don't want to go into these things. Again, I will go to the same thing which Professor Humayun said. That means, first of all, morphological diagnosis is very, very important. And to make a morphological diagnosis, especially in a lymph node, the section, the processing should be excellent, staining should be 100% good. There should not be any compromise in this thing. The technical aspects of this slide must be very good. The slides which Mahbub has shown here, they are very good. But if you look at the slides of other laboratories, I don't want to, what is that, anybody, but most of the laboratories has got the proper sectioning and staining of the slides. So it is difficult to make a diagnosis, not to classify or sub-classify. So this is one thing I should rather say, more good sectioning, good staining. Then what to say, this is for the juniors, that means the students, that you look at this slide on the lowest magnification. I remember while I was at Hammersmith, my professor of pathology used to look at lymph node slide. He was a lymph node expert. C.B. Harrison at that time, he was the professor of pathology, and he was one of the pioneers of the diagnosis of different subclassification of lymphomas, including benign type of Hodgkin disease, the so-called nodular sclerosis, which used to be called as benign. He gave the terminology as benign Hodgkin's disease. But in any way, he used to see the lymph node section by that, the watchmakers things. The watchmaker used to see this thing with that thing. He used to see it first to see the morphology. Then he used to look at the low magnification, then high magnification. So I should rather advise the juniors, that means the students or your trainee, that you won't get the watchman's this thing nowadays. I don't think anybody are using nowadays. So what you do, you can buy a pocket magnifying glass and keep it with you. Look under this magnifying glass the overall morphology of the slide, and then put under low magnification and suite, and then examine it. I won't go into the details of this. Humayun and Kamal has given is very, very important. You make a diagnosis, morphological diagnosis, and in our country, I wouldn't go into, if I say that every lab should do all the markers, it will be nothing. It will not, because they haven't got sufficient sample. They haven't got to do the study marker study, and those markers are very expensive, and they have got a short life time, or so it will be possible for you to run it. So what you do, you make a diagnosis. Kamal has said very rightly that you say it's possibly it's a non-Hodgkin's lymphoma to be confirmed by immunohistochemistry. You can send this slide to somebody who is doing it properly, or you can ask somebody to extend some of your slide, whatever way you think better. I would rather go in that way. All the labs should not try to do, they should not do the immunohistochemistry. It needs a lot of investment. It needs a lot of experience. Then if you do this sort of thing, you will do a lot harm to the patient, a lot harm to the country. Instead of doing this, do a proper morphological study under your H&E. Then what we used to do at that time, nobody is using nowadays. It was a routine for lymph node, stain H&E, routinely reticulin, Van-Giesen, that means fibrous tissue staining, and MGP, methyl green pyronine. This used to be routine. That should come. Nowadays, nobody is using those normal histochemistry. But I can tell you that reticulin gives you a very, very good impression if you want to see a lymphoma properly. But in any way, I won't go into the background, but reticulin stain is not difficult. Any lab can do it. MGP, you can do it. It is not expensive. You can do it. H&E, obviously, but some of the labs, they can't do the proper H&E staining. So what you were talking about, the sub-classification of non-Hodgkin B-cell or non-Hodgkin's lymphoma or Hodgkin's lymphoma. So I fully endorse the view of Professor Kamal and Professor Humayun, as he is staying in USA. He can do it because they are not purchasing all the, because some of the labs, they are producing their own antibodies. So it is not difficult. So they can have 40, 50 antibodies to run it. So, but it is not the same case in our country. You can't get supply from the supplier. So, and it's very expensive. The shelf life is very short, and because it doesn't fulfill our criteria to this. So I would thank you again for asking me to join in your meeting. Thank you very much. I enjoyed today's session very much. Thank you again. Glad to see Humayun after a long time. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Dr. Nasim, you can offer Dr. Khalid one.
Yeah, Dr. Khalid, please. Dr. Khalid.
If you want.
If you want to have some comment on this session.
Probably Dr. Khalid is there or left. I don't know.
Dr. Khalid. Khalid ki nahi hu. আচ্ছা ডক্টর মাহবুব আপনাকে একটা প্রশ্ন আমার করতে যাচ্ছিলাম
প্লিজ
ওই যে হ্যান্স একটা অ্যালগরিদম আছে না হেলথ অ্যালগরিদম এটা একটু ইলাবোরেট যদি করেন যদি আমাদের বিগিনারদের জন্য মনে হয় একটু সুবিধা হয় এই সময়টা ঠিক ধরতে পারি নাই
Actually, Dr. Humayun can answer this question very better way. And actually, on the basis of cell of origin, you know that the DLB cells arises from the germinal center is a dynamic microenvironment, and within that environment, there is a difference. One is in the some mutational reason. The one is called germinal center origin, another is activated B cells. It is before the maturation, it is transformed into the malignant cells. So it is actually ideally we have to identify these two types of cell by gene expression profile or other molecular technique. But that is the largest laboratory also. So we can predict these cell types on the basis of immunohistochemistry. There are different types of algorithm, one to many algorithm, but most widely used algorithm is Hans algorithm. That algorithm will use 3 markers: CD10, MAM1, and BCL6. So 3 markers. You can see the slide. You can find anywhere this algorithm. If tumor cells are CD10 positive, straight away you can call it a germinal center origin. And if the tumor is MAM1 positive, it is of course it is the CD10 negative, so that is a non-germinal center type or activated B cell type. And if it is a BCL6 positive, CD10 negative, in that case it's required. BCL is positive and MAM1 positive, then again it is a non-germinal center activated B cells one. But BCL6 negative, BCL6 positive, MAM1 negative, that is a germinal center type. In this way, and it corresponds with the German gene expression profile is about 70 to 80% cases. Am I correct, Dr.
Yes.
Humayun Kamal?
Yeah, you right. So you can go step by step. Just look at the CD10. If positive is GC. If 10 is negative, look at MUM1. If positive, activated B cell. If 10 negative, MUM1 negative, look at BCL2. If positive, germinal center, negative, activated B cell. So 3 steps.
Thank you. That corresponds with the prognosis also. Activated B cell type is much more aggressive. Achha, now regarding rituximab, whether Hans algorithm still holds true. Rituximab পর এই যে ট্রিটমেন্টের অপশনস হিসেবে এখন অতটা কি দরকার পড়ে এখন আমাদের এই জার্মিনাল সেন্টার টাইপ আর অ্যাক্টিভেটেড বি সেল টাইপ ডিফারেন্সিয়েট করা?
Actually, right one.
Okay, I mean, I will chip in over there. As I mentioned, depending on where the patient is getting treatment, it will determine what chemo is available, what options are available. Not everywhere, every option is available. Where I practice, it makes a difference. They always will be asking that because as was in my comments, I was mentioning, if it is germinal center type, they will go for R-CHOP. If it is activated B cell type, then they will go for R-CHOP plus, whether hyper-CVAX or other additional drugs added to the R-CHOP therapies.
Thank you. Now, any comment from Professor Kamal স্যারকে আমি একটু বলতে যাচ্ছি। স্যার যেটা বলেছিলেন যে আমাদের এখানে তো কিছু প্রবলেম আছে ইমিউনোহিস্টোকেমিস্ট্রি চালু করার ব্যাপারে। অল্প কিছু সেন্টার আমাদের এখানে ইমিউনোহিস্টোকেমিস্ট্রি হচ্ছে এবং ইট ইজ আসলে যথেষ্ট খরচের ব্যাপার। সবাই এরকম রাজিও হয় না এবং এগুলোর আমাদের যে মার্কারগুলো আমরা আনি সেই মার্কার লিমিটেশনস আছে। তো এটা যদি ভালো হয় যে এখানে একটা সিস্টেম করা যায় যে কোঅপারেশন বিটুইন দ্য ভেরিয়াস ইনস্টিটিউটস যেখানে বা সেন্টার্স যেখানে মার্কার যদি কারো না থাকে তাহলে আমরা সেটাকে শেয়ার করতে পারি। আমরা এই জিনিসটা যদি করি তাহলে আমাদের এই প্রবলেমটা আমরা ওভারকাম করতে পারবো।
বলবো?
হ্যাঁ স্যার।
আচ্ছা, এটা করা সম্ভব। এটা বিএপি ব্যানারে হতে পারে। যারা করি আমরা যদি একসাথে বুঝতে পারি এবং এটা আমাদের কি কি আছে এবং একটা টার্মস এন্ড কন্ডিশনস কিছু তো থাকেই। যেমন এডুকেশনাল ইনস্টিটিউট গুলোতে তো কোনো সমস্যা নেই, হ্যাঁ, সেটা হতে পারে, কিন্তু তারপরও লিমিটেশনস আছে কিছু, মানে প্রচুর করছে যারা করছে, যেমন বিএসএমএমইউ, মানে এত কাজের চাপ যে সেখানে এগুলো করতে গিয়ে ওদের হয়তো একটু প্রবলেম হতে পারে বা অন্যদেরও হতে পারে। তো লিমিটেড কিছু জিনিস যখন খুবই প্রয়োজন ওই অংশটা সেকশন করার সময় আমার মনে কিছু সেকশন বেশি রাখা যদি প্রয়োজন হয় এটা ব্যানারে করা যেতে পারে যে আমরা যারা করব, মানে একই জিনিস একাধিক সেন্টারে না থেকে কয়েকটা সেন্টার, কতগুলো জিনিস আছে যে সবারই থাকবে, আর বাকি সেন্টারগুলো হচ্ছে স্পেশালিটি বায়াসড বেস যারা একটা ভাবে গড়ে উঠবে। এরকম ভাবে করা সম্ভব হয়তো কিছুটা।
স্যার একটা পয়েন্ট একটু স্যার ক্লিয়ার করতে পারি স্যার, যদি কাইন্ডলি পারমিশন দেন স্যার।
হ্যাঁ শিওর
স্যার, আমার কাছে কিন্তু একটা একদম হলো, সেটা হলো যে আমাদের দেশে টিস্যু প্রসেসিং, টিস্যু ফিক্স, এটার ব্যাপারে স্যার আমাদের একটু না নিলে স্যার এটা হচ্ছে না স্যার। ভুল ডায়াগনোসিস হয়ে যায়, বাজে ডায়াগনোসিস হয়ে যায় শুধুমাত্র
বলি
স্যার।
ওয়াসিম,
স্যার
কি করবেন আপনি এখানে? ডিফিকাল্ট হয়ে যাচ্ছে, হ্যাঁ, ফরমালিন পাওয়া ডিফিকাল্ট হয়ে যাচ্ছে।
এটার জন্য স্যার
সাধারণ ব্যবসায়ীরা হ্যাঁ, যারা নিজেরা ইম্পোর্ট করে তারা ভালো। এখন এটাও একটা ব্যাপার যে যদি ইম্পোর্ট মানে একটা আমাদের এরকম উইং থাকে যারা এটা ইম্পোর্ট করতে পারে, কোনো একজন ব্যবসায়ীর থ্রুতেই হোক এবং আমরা সেখান থেকে নিব, তাহলে কিন্তু হতে পারে। In that case, small laboratories will be benefited. আরেকটা জিনিস আমি একটু বলি, একটু সরি, এটা সুযোগ পেলাম বলে বলছি যে there are big labs যারা they have their own good processing center, আর small labs যারা ওরকম পারে না। কিন্তু এটা হচ্ছে যে why আমরা একটা সেন্ট্রালি একটা বড় ল্যাব করতে পারি, যে ল্যাবের কাজ হচ্ছে যে এই আমরা ওখানে ব্লক পাঠিয়ে দেব and they will send us the slides, যতগুলো ব্লকের উপর করে। this is like a business, হ্যাঁ, তারা এটা রান করবে একটা, যে তারা এই ব্লক সেটা ভালো মানে তারা ম্যানেজার থাকবে, তারা ডায়াগনোসিস সাথে কিছু না, আমরা গ্রস করছি, টিস্যু পাঠিয়ে দিচ্ছি, কি কি আমাদের রিকোয়ারমেন্টস পাঠিয়ে দিচ্ছি, ওরা করছে, আমরা ওটা দেখছি, দরকার হলে সেখানে আবার ইমিউনের জন্য পাঠিয়ে দিচ্ছি। এটা থার্ড পয়েন্ট হচ্ছে স্লাইড ব্লকও ওরা রাখতে পারে অথবা আরেকটা প্রতিষ্ঠান, তাহলে আমাদের নিজেদের স্পেস অনেক বাঁচবে এবং আমরা আমাদের কাজে কনসেন্ট্রেট করতে পারবো। এটা একটা যদি কেউ নেয়, এটা কোয়াইট একজন বিজনেস হিসেবেও নিতে পারে, হ্যাঁ, যে এটা মানে ভালো বিজনেস, কারণ আমরা প্রতি স্লাইডে হ্যান্ডসাম অ্যামাউন্ট অফ টাকা দিব, কিন্তু আমরা কোয়ালিটি জিনিস পাবো।
রাইট স্যার। স্যার স্পেশালি স্যার মানে যদি স্যার ফিক্সেশনটা ভালো হয় স্যার, মানে যেটা হয় স্যার যে আমার যদি শুধুমাত্র ফরমালিনটা ভালো হয় স্যার, তাহলে যেটা হয় কি স্যার যে যখন ব্লকটা আসতেছে স্যার আমি কিন্তু তখন কেটে স্যার আমি তৈরি করতে পারছি। কিন্তু যদি আমার মানে আমার কাছে মনে হয় প্রথম জিনিস ফরমালিন ঝামেলাটা মেটানো স্যার খুবই জরুরি। দেখেন
আমার নিজের
শুধু এটার জন্য স্যার এত বাজে অ্যাক্সেস হয়ে যাচ্ছে স্যার।
ইভেন উইথ দিস ফরমালিন আমি কতগুলো জিনিস দেখেছি, অবজার্ভ যে ইফ দ্য স্পেসিমেনটা বায়োপসি করার পর অ্যাডিকুয়েট টাইম ফরমালিনে অ্যাডিকুয়েটলি রাখা, অ্যাডিকুয়েট অ্যামাউন্ট, এটা স্লাইস যদি বড় হয় তাহলে স্লাইস করে ঠিক করে রাখতে হবে, তারপর গ্রসিং এর পরও ফরমালিনে রাখতে হবে, এবং ওই অ্যাজিটেট যদি করেন আপনি একটু অ্যাজিটেটের মধ্যে রাখেন তাহলে আরো ভালো হয়, একটু ওয়ার্ম যদি করেন আরো ভালো হয়। দিস ইজ মাই এক্সপিরিয়েন্স, যে দেখেছি যে টিস্যুগুলা একদিন টিস্যু প্রসেসর চলেনি কিন্তু ফরমালিনে ছিল, পরের দিন খুব ভালো হয়ে গেছে। হ্যাঁ, সো এইসব জিনিসগুলো নির্ভর করে, যদি ফরমালিনটা অত ভালো নাও হয় একটু মানে এই প্রসেসগুলো ফলো করলে যে একটু বেশি সময় থাকবে, অ্যাজিটেট করবে। এখানে তো আমাদের দেশে ওই লোকের অভাব নাই যে মানে যে নাড়াবে বসে বসে, তার কাজই হচ্ছে এরকম ধরনের, তাহলে হয়তো বেটার, মানে যা আছে তার থেকে বেটার। আর ডিউরিং মাই ওয়ার্ক ইন বিএসএমইউ আমি দেখেছি যে অ্যাকচুয়ালি ইমিউনো মোটামুটি ভালোই হয়। ইমিউনোটা কেন যেন মানে ইভেন পার্টলি নেক্রোজ টিস্যু, অটোলাইজ টিস্যুর মধ্যেও আমি ভালোই পেতাম। হ্যাঁ, সো ইমিউনো এটা হয়তো মানে অ্যান্টিজেন গুলা থেকে যায় যতই ইয়ে হোক, তাও দিস ইজ নট এক্সকিউজ ফর মানে গুড ফিক্সেশন। হ্যাঁ,
মানে সত্যি কথা বলতে স্যার লিম্ফোমা ডায়াগনোসিস শুরু হবে স্যার গুড একটা প্রপারলি ফিক্সড টিস্যু না হলে স্যার তো ডায়াগনোসিস
ফিক্স প্রপারলি সেকশন টিস্যু
আদারওয়াইজ তো করাই যায় না করাই যায় না স্যার। মানে এমন সময় আসে যে লিম্ফোমা ডায়াগনোসিস দিয়ে বসে আছে স্যার একজন, আমার কাছে যখন আসলো স্যার আমি তখন আর ডিসাইড করতে পারছি না এটা কিভাবে করি, বুঝতেছি যে এটা লিম্ফোমা হওয়ার চান্স নাই, এরপরও স্যার ইয়ে করতে পারছি না, ইমিউনো ধরতেছে না স্যার, ঠিকমতো মরফোলজিক্যালি ইভ্যালুয়েট করা যাচ্ছে, এটা ডিফিকাল্ট,
একেবারেই মানে খুব বাজে অবস্থা হয়ে যায়, তখন খুবই প্রবলেমে পড়ে। আর আরেকটা জিনিস দেখেন, আমাদের যে মানে যে কস্ট, যে পেশেন্ট ডিএমসি তে বহু কষ্ট করে এসে ভর্তি হয়েছে, আপনি তাকে ইমিউনের জন্য পাঠাচ্ছেন বিএসএমইউ তে 10,000, সে দেবে না, সে পারবেই না। তো ডায়াগনোসিস হলো, তারপর যে ট্রিটমেন্ট, সো আমাদের চেষ্টা করতে হবে যে আমাদের ডায়াগনোসিসটা হিস্টোলজিতে যদি সম্ভব হয় একে প্রোভাইড করা।
অবভিয়াসলি স্যার। স্যার আমি শুধু একটা জিনিস একটু বলতে চাই আপনার কথার প্রেক্ষিতে স্যার, আজকাল স্যার পেশেন্ট যখন স্যার একজন পেশেন্ট স্পেশালি যখন সে ক্যান্সার নিয়ে যখন সে আসে স্যার, আলটিমেটলি ক্যান্সার ডায়াগনোসিস হওয়ার পরে কিন্তু লাখস অফ টাকা সে খরচ করছে স্যার, কিন্তু ডায়াগনোসিস করবার জন্য স্যার আমার কিন্তু স্যার এখন সত্যি কথা যেমন বিএসএমইউ স্যার মোটামুটি 10 থেকে 12,000 টাকাতে একটা যতটুকু লাগে দিয়ে দিচ্ছে স্যার। আমরা আমাদের এফএফ কিন্তু স্যার 10-12 হাজার টাকার মধ্যে স্যার যতটুকু লাগছে আমরা দিয়ে দিচ্ছি, মোটামুটি রিজনেবল হয়ে যাচ্ছে স্যার। 10-12 হাজার টাকা কিন্তু আসলে খরচ করা সম্ভব, এখন অনেকে করে স্যার খরচ। মানে যেটা হচ্ছে আমাদের মেন্টালিটি চেঞ্জ করতে হবে।
হচ্ছে যে দেখেন
স্যার
লিম্ফোমা ডায়াগনোসিস হলে তার খরচ করাটা কিন্তু সঙ্গত, কারণ দিস ইজ পটেনশিয়ালি কিউরেবল ডিজিজ। সুতরাং আমাদের ওইটা মনে করতে হবে যে whether it is lymphoma or a reactive process or some other, এই ডিফারেন্সিয়েটটা যদি আমরা হিস্টোলজিতে করে দিতে পারি then it is very
স্যার। রাইট স্যার। স্যার আমি যেরকম পার্সোনালি স্যার যখন সার্কোমা যখন আসে স্যার তখন বেশি খরচ করি না স্যার, বিকজ জানি যে স্যার এটাতে আসলে করে লাভ নেই স্যার, এখানে খালি খালি পেশেন্টের খরচ করার কোনো লাভ নেই। কিন্তু সেটা গেছে একটু ইয়ে করে চিন্তা করে স্যার করলে স্যার পেশেন্টের
ডেফিনেটলি এটা
স্যার।
থ্যাঙ্কস। আমাদের নেক্সট প্রেজেন্টেশনে এই মুহূর্তে কোনো ঘোষণা দিতে পারছি না, কিন্তু আমার মনে হয় যে আমাদের মেম্বার্স যারা আছেন তারা কেউ যদি প্রেজেন্ট করতে চান অবশ্যই ইনিশিয়েটিভ নেবেন। অলসো হুমায়ুন কামাল, আপনি চাইলে আমাদের এখানে প্রেজেন্ট করতে পারেন। ইফ পসিবল প্রফেসর এমবি জামান স্যার কেউ যদি মানে বলতে পারেন তাহলে স্যার যদি উনি ইন্টারেস্ট নেন তাহলে উনি প্রেজেন্ট করতে পারেন আমাদের এখানে। মনোয়ার কেউ বলতে পারেন। আপনারা তিনজন মানে কামাল জামাল স্যারের সঙ্গে সবসময় এসেছেন এবং অনেকগুলো পোস্ট গ্রাজুয়েট কোর্স আমাদের এখানে নিয়েছিলেন। তো ইন লাইন অফ দ্যাট যে এখনো যদি আপনারা, এখন তো কোভিডের জন্য আমরা চাইলেও এখন ফিজিক্যালি এই ধরনের আয়োজন করতে পারবো না, সুতরাং এটাই ভরসা। এই ধরনের এই প্রেজেন্টেশন আপনারা যদি করতে চান তাহলে করতে পারবেন। উইল বি ভেরি মাচ ডিলাইটেড। হুমায়ুন কামাল
ইনিশিয়েটিভ হবে এটা, যে একটা সাবজেক্ট একটা টপিক ধরে সেটা একটা ওয়েবিনারে আমরা করতে পারি এবং সিরিজ অফ লেকচারস হতে পারে, ভালো হবে। স্যারকে একটু অ্যাপ্রোচ করবেন।
Contact with Professor Zaman. I see him every month, so I'll definitely bring it to his attention and look forward to that. So if you permit me, I'll have to leave now for my next meeting.
Thank
you. It was very wonderful to see you.
Thank you, Dr. Humal, for presence and
morning.
Thank you so much.
Thank you very much. সৌমিত্র কিছু বলবেন কি? সৌমিত্র চক্রবর্তী।
স্যার শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে।
আচ্ছা, actually this is a very good learning opportunity for us who are junior pathologists, and we are looking forward to lively academic discussions like this one in the future. And today's video has been recorded. I will forward the recording to Dr. Kabir sir, and he can share with the other people who were attended or maybe missed today's presentation. And also, with the permission of today's presenter, it can be uploaded to YouTube or any social media to be shared on the website of BAP, which will be coordinated by Sir Dr. Sadiqul Islam Talukdar sir, and after the recording will take a little bit of processing, so maybe by tomorrow I'll be able to forward the email to Kabir sir. And thank you very much, and I'm also grateful to be able to host the technical side of this endeavor, and I'm looking forward to play the same role in future webinars arranged by BAP. Thank you.
Thanks, Soumitra.
Thank you, Soumitra, for your taking paid. And If you actually, I have no problem from my side to upload it anywhere, but problem is that is it that much quality or not? That is a question. We can see that if can upload. Right, sir.
Very nice presentation. Very nice presentation, and micro photographs were also very nice. The only problem was we have limited time and face-to-face interaction, but it is very good, very good.
No, I was trying to, because I have many cases and all these things, but I try to limit it to within time. But,
I think this presentation was meant for the pathologists who have already some experience in
right, right,
and not for the beginners.
Right.
But you can also take, or anybody can take up a class for the beginners. One or two more than actually lymphoma is a vast field, isn't it?
Right.
Yeah.
Thank you, sir. Sir, আমি ডাক্তার সাদিকুল ইসলাম তালুকদার বলতেছি। আমাদের যে ওয়েবসাইট আছে, ওয়েবসাইটে সুন্দর হয় যেটা এমবেড করলে, যদি ইউটিউবে এটা আপলোড করা হয় তাহলে এমবেড করার জন্য সুবিধা হয়, তাহলে ওখান থেকে ডাইরেক্ট দেখা যায় ক্লিক করে। এই জন্য আমি চাবো যে এটা ইউটিউবে যদি আপলোড করা হয় মাহবুব ভাই নিজের অথবা আপনাদের কারো ইউটিউবে, তাহলে আমরা ওখানে লিংক দিয়ে যেই এমবেড করা যাবে আমাদের ওয়েবসাইটে ডাইরেক্ট, যেমন আগেরটাও কিন্তু এমবেড করা হয়েছে। আর যেটা শুধু লিংক দেওয়া হয় সেটাকে ক্লিক করলে ওটা ঘুরে আরেক দিকে চলে যায়। আমরা এই এমবেড করতে হলে বেশি সুবিধা হয়, ডাইরেক্ট আমরা বসে বসে আমাদের ওয়েবসাইটে।
ওই এমবেড তো আপনি করবেন?
আমি এমবেড করব, কিন্তু এটা ইউটিউবে আপলোড থাকতে হবে।
আপলোড করতে হবে, যিনি ইয়ে করে ওটা সৌমিত্র করে দিতে পারবে।
হ্যাঁ, তার নিজস্ব, তাদের মানে ইউটিউবে একদম নিজস্ব ইউটিউব থাকতে হবে। থ্যাংক ইউ স্যার।
Actually, I intentionally refrained from uploading these to YouTube because then it will show content from my personal account or channel. So for this reason, I refrained from uploading it myself.
It is better to upload Dr. Mahbub Bhai.
I never uploaded, but I will try. I will try if I get the thing.
It is easy. It is easy. You can.
It's all right.
Right.
Dr. Mahbub, how did you manage the background? এটা আমি দেখেছিলাম